First, Dr. Alok. Dr. Alok is a friend and senior and alumni of All India Institute of Medical Science, Department of Pathology. And what I regard, he is one of the most experienced renal pathologists in today's time. And at the Lalpath lab, he sees annually more than around 5,000 of the renal biopsies. And
25,000.
yeah, and he has many accolades in his credit, and he is a speaker to several of the international national medical colleges and recipient of various prestigious awards. And most importantly, he is the creator and webmaster of the globally acclaimed and widely accessed website on the renal pathology, that is www.nephropathology.com. And I think some of the attendees today might like to see that also. And he is also an editor of the Indian Society of Renal and Transplantation Pathology, that is ISRTP, and it is the apex body of the renal pathologist in India. So with that, I will ask or request Dr. Alok to start today's presentation, and we'll tell you whenever there is a question in between. Thank you.
Thank you, Dr. Prasenjit. Thank you for the introduction, and thanks for having me here and sharing some of my expertise and little bit of presentation with you. So what I'll do today. Okay, I think the full screen is visible right now.
Yes, yes.
So we will begin. The way I've outlined this talk is in the first part, I will just take you through the basics of renal pathology, because many of you might not be having exposure even in your labs or colleges to how a renal biopsy is processed and some basics of how to see that biopsy. And then I think we had shared a few cases earlier. So once we are done with that first part, we will take up those 5 or 6 cases one by one. So mostly we'll be focused on the glomerular diseases today, because it's not possible to cover everything in one. So we'll have the basics and a good amount of glomerular today. Maybe if there is another session, we'll take up the tubulointerstitial diseases, right? So before we start, it is important to know what a renal pathologist does. So when you talk about renal pathology, there are two parts of it. So one is the medical renal diseases, in which you have proteinuria, unexplained hematuria, renal dysfunction. So basically all benign kind of conditions. And as a nephropathologist, in general global parlance, we do not look at tumors. So tumor comes in a different domain, and a renal pathologist, if you want to call it that way, is predominantly dealing with the medical renal disease. So diseases which have proteinuria, hematuria, AKI, CKD, and all this, for which biopsy is done, including a very important part of transplant biopsies, falls under the domain of renal pathology or the medical renal pathology. So we deal with biopsies. So most of these biopsies, in fact, very, very vast majority of them are core biopsies. They're taken with the help of a biopsy gun. They come in form of linear cores, and renal allograft is placed slightly different in the iliac fossa. So there is a different place where the biopsies are taken. But the bottom line is all of them are taken with a biopsy gun, and we get cores of biopsies, because that is very important on when you actually process or cut or stain other things. It is important to be aware of this type of sample which you are receiving. Now, as you must have seen in the last slide, it's not an easy procedure, right? It's an invasive procedure which cannot be done again, and it has its own complications. So there are certain conditions where at the time of biopsy, you need to be sure whether you have taken the correct sample or not, right? And the adequate sample in terms of most of the renal biopsies where we are suspecting glomerular diseases, we need to be sure whether there are glomeruli or not, right? So there are techniques by which on bedside, you can identify the glomeruli in the tissue specimen itself. So you can either take a hand lens or a dissecting microscope, as I've shown you here, and then you can try to see if you can look at the glomeruli. So these roundish structures which you are seeing here are actually glomeruli. So it's a core which has just been taken out of the body. It is placed on a slide and viewed under the dissection microscope. So you can be sure that you have enough cortex or glomeruli to be able to process that. So if you don't have it, you can ask the clinician, or clinician himself can go back and do the biopsy again. So it's an important procedure to undertake. Having said that, it's not mandatory. So with time, the clinicians have experience. They can take the biopsy. 99% they'll get it. But especially in biopsies for children, pediatric cases where you absolutely need to be certain that there are glomeruli, this is a useful technique to master. Now, another thing in renal biopsies, which is slightly different from other branches of pathology, is it's a multi-parametric analysis in each and every case. So unless you have all the modalities done on a biopsy upfront, it will be difficult for you to reach a good diagnosis. So for every case, you have to do a intensive light microscope examination. That goes without saying. You also need to do a DIF, the direct immunofluorescence examination, and you also need to have ultrastructure examination, preferably in all the cases. And it is only when you have done all these three together on the same case will you be able to reach a diagnosis. So it's not something which you do post facto. You see something and then you start doing something. So you have to do all these things upfront. Now, having said that, you must have realized it's a small specimen, right? So you need to be triaging the specimen also very well. So you can't have key, I have done this now, is suspecting this. Now you go back to your block and start cutting sections again. The tissue will deplete. So you have to have a very clear strategy in your mind of how you are going to deal with that renal biopsy and perform maximum possible diagnostic procedures on it to get a diagnosis, right? So this multi-parametric approach or analysis is a key to a good renal pathology report. Now, unlike many other specialties, upfront you have to have three specimens for the three main modalities which we just spoke about. So we talked about the light microscopy, for which you need to take the 10% neutral buffered formalin. For EM, you need to take a separate specimen in a separate fixative again, buffered EM grade glutathione solution. And direct immunofluorescence, although we do not use any fixative, but you need to put it in a transport medium. So the most commonly used transport medium is the Michel's fluid, which you can prepare in your own laboratory. So there have to be three cores, at least in the vials. You can take two cores and divide one and then put in two. But at least there need to be three specimen in per case if you are doing electron microscopy to be able to do a good renal pathology examination. Now, in terms of light microscope examination, the processing is as usual as you do the routine biopsies otherwise also. But the difference comes when you cut it. So you need to cut the renal biopsies in very thin serial section, just like a CT scan. So you think of biopsy as a CT scan. You keep on taking slices from top to bottom. That is how it is taken up. And for each case, at least in our lab, we take around 30 to 45 serial sections. And then when we put them on sequentially numbered slides. And it's very important to note that the paraffins, the sections have to be cut at around 2.5 to 3 microns. This allows a good examination. The morphology is very good. And a lot of criteria which are put up in renal pathology in terms of cellularity and other things are globally standardized based on the thickness of the sections. So you have to follow that pattern of 3 micron maximum thickness for light microscopy. And another difference is the stains which are considered special in routine histopathology are routine in renal pathology. So apart from HE, you do a PAS, a silver methylamine stain, a Mason's trichrome stain, and in our lab, a Congo red stain on each and every biopsy. So these stains are actually routine in renal pathology. The reason for doing these stains, we just spoke about these stains, right? The reason for doing all these stains is because there are various compartments of the renal parenchyma, which you need to highlight by doing these special stains. So doing a single stain or just doing an H&E stain on every biopsy will deprive you of a good examination of several other parameters that includes mesangial matrix, basement membrane. So the ones which have been highlighted in red in this particular slide, you can see. Excuse me. So the PAS stain is good for basement membrane and mesangial matrix. Jones is the silver methylamine stain. Jones modification of the silver methylamine stain. It will color the basement membranes and mesangial matrix black. When you want to look at interstitial collagen, you need to have a good Mason's trichrome stain in place. When you want to look at immune complexes, you need to have a combination of stains. The immune complexes are negative in silver stain, are positive in PA stain, and shine a bright red in Mason's trichrome stain. And amyloid, as we all know, we need to do Congo red stain to pick up amyloid. Having said that, even a negative staining for amyloid is a very helpful feature in the sense when you take up a PA stain and you find that there is something in the glomerulus which is negative, it doesn't stain, and you can start suspecting a amyloid there. So these are the criteria which you need to keep in mind. And this is the reason we do multiple stains, so that we don't miss out on a good examination of any of the parenchymal elements, right? So this is just a slide which tells you the appearance of glomeruli in different stains. So you have an HE stain right here. The PA stain, if you notice, it will color the Bowman's capsule in a magenta colored hue. And same would go for the mesangial matrix. So you can see here, if you compare the left and the right side images, you can very well see that the mesangial matrix is much better visualized in the PA stain section, right? Then you have the Mason's trichome. You can see these outside areas which are blue. This is interstitial collagen. And then you have the silver stain again, where you see the black color of the basement membranes, the Bowman's capsule, the tubular basement membranes, and the mesangial matrix, right? More about this as we take on the cases. I'll keep on telling you one by one. Now, direct immunofluorescence, it is very important to have a complete panel. So unless you have a basic complete panel, you would be missing out on a lot of diagnosis. So this panel would include three main components. So one, you have the heavy chains that includes the
तो
immunoglobulins
उसमें
A.
सर जैसे आप जो कोएगुलेशन का
Then you have the complement components, in which the C3 is the early complement component, the C1q is the late complement component, and then you have both the light chains, the kappa and lambda. So you need to have a panel of at least all these 7 in each and every case. You have to have these. So unless you do it, and apart from this, there are certain other things which you may choose to have depending on the case mix you have or on the level of advancement your laboratory is. You can use albumin. Fibrinogen is useful when you have areas of necrosis. You get fibrin deposition there. An IgG subclass, I would suggest, if any lab is doing renal pathology, you need to have IgG subclasses. So IgG subclasses give you insight into the pathogenesis of disease. So each subclass has a different function. IgG3 is a good fixator of the complement. IgG1 doesn't fix complement. IgG4 has a different role. So all these four in different combination point towards different patterns of diseases or different pathogenesis. It's a good idea to keep a IgG subclass also. And if you have noticed, people who have not seen immunofluorescence, all the images appear green, right? That's because the most common fluorophore, the fluorophore which is tagged to these antibodies is the FITC, which is called the fluorescein isothiocyanate. So it works in the blue spectrum and gives a greenish fluorescence. And recently we've had a new fluorophore, which is called the Alexa fluor. It is slightly more expensive. But what it does is it has a more it's more stable, in the sense, even if you are keeping the slides of fluorescence for a few weeks or even few months, the fluorescence does not leach out. So these are developments which are slowly happening in our field. So on the left side, you can see this image. So this is a glomerulus in which you can see these greenish areas which are positive in the mesangium of the glomerulus. So if it was IgA, this would be an Secondly, I just talked about the immunofluorescence. So I told you about that. So it's a blue spectrum in which FITC works. And these are just showing you the cryo. So the cryostat which we use for cutting frozen sections is the same as you use in our laboratory. There's no difference there. Only thing, the sections are cut slightly thinner here compared to the frozen section. So we try to cut our sections for even for our direct immunofluorescence around 5 to 6 microns. So that gives you a good visualization on the slide. So you can do that. Now the last part, the electron microscopy. So you need to have a basic idea about electron microscopy as well. So as I told you earlier, for electron microscopy, we use tissue which is fixed in 3% or 3.5% buffered EM grade glutaraldehyde solution. So why I'm emphasizing so much on EM grade is in hospitals and other labs, you have Sidex, which is glutaraldehyde. But Sidex, remember, it is for disinfection. It is an impure form of glutaraldehyde which cannot be used to fix this specimen. So if you want to fix tissue specimen for electron microscopy, you need to use the EM grade glutaraldehyde solution and do appropriate buffering and make it around 3%. And what you see on the left side are the blocks. So instead of paraffin, which we use in the routine histology laboratory, to fix the specimen, we use resin. So these resins most commonly are araldite resins. So you must have heard about araldite. So araldite is the resin which we use to embed the biological specimen for electron microscopy. The reason being, see, eventually what will happen, just like we incident light, ambient light to look at routine sections, what we will do in electron microscopy is we will incident the electrons. Electrons have got a very high potential, right? They have a very high speed, they travel in vacuum. And unless you have a tissue which is held on to a very good background, it will rupture out. So that is the reason those resin, we use resin to make up blocks. These are very small blocks, and actually when the final sections are cut, they are taken up on this grid. So this grid is actually equivalent of the glass slides which we use in routine histology. And you can see the size, it's just 3 mm, and the thickness of this grid is only 20 micron. And since it is so small, you need to cut these sections under a special microtome, which is called as the ultra microtome, which I have depicted here. So you need a separate setup and a lot of expertise to be trained and developed if you want to put up an electron microscope lab. And this is the electron microscope. So usually we, in biological sciences, you don't need more than 80 kilovolt accelerating voltage for the electrons. If you want to go to a higher atomic level, you would need high accelerating voltage. But for us, 80 to 100 kilovolts is an adequate accelerating voltage to have a good visualization. And finally, when you have the grids prepared and you start looking at it under the electron microscope, this is how a glomerulus would look like. So what you see here is a glomerular capillary, which I'm highlighting with the pointer here. And these structures which you are seeing like emanating just like hair on end appearance, if you want to call it, in an X-ray which we see. So these are the terminal processes of podocyte, the visceral epithelial cell. This tells you that the podocytes are well preserved in this particular glomerular capillary. You have an endothelial cell here, you have the podocyte cell nucleus here, and you have the Bowman's capsule, because it's a peripheral part of the glomerulus. You can see the Bowman's capsule, right? And if you go down here, where my pointer is now, this is the mesangial area. So mesangium kind of forms a anchoring area from where the glomerular capillaries are anchored, and then they spread out into the Bowman's capsule or the urinary space. So we'll see a few EM pictures down the line. You will learn more about it. So now coming to the approach. So when we approach the renal biopsy, when you, as a diagnostician or as a renal pathologist, when you are asked to look at a renal biopsy, it is a good idea to be strategic in your approach. So you need to look at the various compartments. You look at them together, but you think of them separately, right? So you have the glomeruli, you have the tubules, you have the interstitium, and you have the blood vessels. So if you ensure that you are having a hard look at all the 4 components, your examination would be complete. So I'm talking about predominantly about light microscopy here. And you can train your mind to either look at them one by one, or you can train your mind to look at them all at once. So as you grow in your practice, you will learn the tricks of the trade. So experienced people can do a good examination of all the 4 compartments together. But for a beginner, it is a good practice to start focusing on one compartment at a time. And then when you are done, you try to stitch your findings together to get the analytic process. Now, when you do a routine examination, we just spoke about a lot of stains, right? Which stains well, which area of glomerulus or interstitium stains well without stain. So you need to keep these things in mind when you are looking at the biopsy. And when you look at these individual compartments, what I have enumerated here in this slide are the major things you need to look at. So when you look at the glomerulus, you look at the inflammation, you look at the GBM changes, whether it's thick, thin, broken, whether there is sclerosis or scarring in the glomerulus. We have a case there. We will look at it in a while from now. Whether there is necrosis, whether there is a crescent formation, or if there are any abnormal deposits, we have a case for that as well. So apart from the normal mesangial matrix, is there anything else which is getting deposited there? And you also look at a good look at the cellularity and compare it with the normal, right? So normal would be usually in a mesangial matrix, you will not have more than 3 cells per mesangial area. That's the maximum permissible limit in a 3 micron section. And usually you will not have any cell in the glomerular capillary lumen. So anything more than what is required is an abnormal finding. Similarly, in tubules, you look at the injury, you look at atrophy, you look if there are any atrophic changes, regenerative changes, and you also go inside the lumen and look at the casts and what those casts are. So are these normal casts? Normal in the sense, are these TAM protein casts, or are these abnormal casts, which could even be myeloma casts, right? So you need to look at all those things. And when you look at the interstitium, you look at the infiltrate. So it's a potential space. Normally, you would barely have any interstitium to look at because the tubules are all back to back, glomeruli are there. But whenever there atrophy and fibrosis sets in, you can start seeing those blue areas in mesenteric stain. You look at the atrophy, fibrosis, if there are any cellular infiltrates there, if there is an edema, fibrosis, all those things you need to look at interstitium. And looking at the vessels, you need to look at there is an inflammatory component. If there is sclerosis, subintimal sclerosis, just like you have in hypertension, so-called hypertensive changes. if there is hyalinosis, necrosis, thrombosis, thrombotic microangiopathy. So all these things you need to keep on thinking together and then try to make sense by putting everything into correct clinical context, right? Just like any other specialty, but more so in renal pathology, because once we see the cases, I'll tell you why. Because in although you might have the similar morphology, but if the clinical context is different, your diagnosis changes. So that is where renal pathology is slightly more challenging to practice, because you need a lot of cooperation from the clinicians also, which is not always forthcoming. But that's the bottom line. You need to figure that out. So we've talked about the approach. Now, when you since I will be speaking predominantly about the glomerular diseases today, so there are certain stereotyped clinical syndromes with which the patients present. And once you have the knowledge of these clinical syndromes, it will be very helpful for you to analyze your biopsy, right? So when you have a patient who has got nephrotic, I'm sure everybody knows what nephrotic syndrome is. So when you have a nephrotic syndrome patient, you look at the biopsy in a different manner, right? You pay attention to different compartments. You try to see if there is how the glomeruli are looking, if there is any sclerosis, what is there in IF. When you look at EM, you want to see how much is the effacement of the food processes, because you are dealing with a patient of nephrotic syndrome. Similarly, the acute nephritic syndrome, where the patient also has hematuria in addition to proteinuria. Then there is a syndrome of rapidly progressive glomerulonephritis, where there is a rapid rise in creatinine along with renal dysfunction and maybe hematuria and other things. So that's RPGN or RPRF, if you want to call it. And then there will be some patients who will have just asymptomatic hematuria proteinuria, right? So you undergo an examination as a part of routine screening, and then somebody gets detected with a proteinuria or hematuria. They're not symptomatic for it. But even in those conditions, there could be some very sinister things happening in the kidney which need to be looked into it in an early part of its development. So that's an important part of screening of patients. And then when the disease progresses towards its end stage, you may actually find a patient having chronic renal failure where most of the diagnostic signs, at least in a biopsy, are obscured. So you can have a condition where you get a biopsy, but you are unable to pinpoint the pathology there, because whatever had happened has left its scars behind. So it's very difficult to diagnose those things. And when you put these clinical syndromes into biopsy findings, these are the 9 or 10 main parameters or main patterns of injury which you get in a glomeruli. So when we start from epithelial cell disease, something like a minimal change pattern, nothing on light microscopy, negative IF, but when you look at EM, you get diffuse effacement. So this is epithelial cell disease. You have an MCD, FSGS pattern. Then when immune complexes start forming, you have a membranous pattern nephropathy. I talked about cellularity. So when you have more cellularity in the glomeruli, there is a proliferative pattern. We call it a proliferative pattern. And since these cells are many times inside the glomerular capillaries, we call them endocapillary hypercellularity, right? So you can have a focal or a diffuse pattern of proliferative lesions in the glomeruli. Then you have the membranoproliferative pattern, right? Membranoproliferative pattern refers to thick GBMs which have undergone remodeling and reduplication. So when you look at the GBMs under silver stain or other stains, you will find instead of a single layer, there are two layers. So that's called the membranoproliferative pattern of glomerulonephritis. Then you have an crescentic glomerulonephritis, which usually presents with an RPRF or an RPGN. You can have a mesangoproliferative glomerulonephritis, just like an IgA nephropathy in many cases. And then when there are patients with asymptomatic hematuria and proteinuria, many times you don't find anything on LM and IF. It's only when you do an EM, you may find thin GBMs, you may find signs of early Alport's disease. So those are glomerular basement membrane abnormalities, which you pick up as a part of the multi-parametric analysis, which I was talking about. And then you have the end stage kind of a picture where you get focal global glomerulosclerosis, right? So this was in brief about the patterns and the approaches and the laboratory aspects of renal diseases. So if you have any questions, you are most welcome to keep on asking those questions, not an interruption at all. Keep on asking them. So I have covered glomerular patterns here. I've covered the laboratory part. And now since we go out with the cases, we can keep on discussing more and more things, right? So I'm sure you must have seen the cases. I think there were six cases there, and we can take them up one by one, right? So this was the first case. I think I can toggle between the scanned slides also. So just give me a moment. So we'll start with the first history. So this was a 45-year-old female who had a swelling over face and feet since 1 month. and recent hypertension. And before doing a biopsy, she was also treated empirically with steroids for 3 weeks. So that's what usually happens. The clinician, whenever the patient presents with a nephrotic syndrome, will not do a biopsy upfront. It will always, so when the clinician is convinced that this patient has a nephrotic syndrome, they will most of the times give a trial of steroids just to see whether that steroid therapy is actually inducing remission without having being resorting to a biopsy. So that's what is usually done. But when this patient was given steroids for 3 to 4 weeks, she did not respond. So there was no remission of proteinuria. And the investigations, you had a typical nephrotic syndrome with nephrotic proteinuria more than 3 grams per day. Renal functions were normal. There was dyslipidemia and hypoalbuminemia. So you have a serum albumin, which was only 1.7 grams of a total of 6.3 grams of protein and other viral markers. So this patient had a typical nephrotic syndrome. Only abnormal thing is she had hypertension and she had not responded to steroids. That was the only abnormal thing, right? So we can take up the biopsy if I can toggle between the Dr. Pasijit, is it possible to have those things together?
Sir, you can show in the path presenter, minimize
show
it
the-
and yeah,
Okay.
yes, sir.
Okay, fine. I'll do that. So is it visible now, Sanjit?
Sir, probably only the presentation is shared. Maybe you can share your entire screen. Then you
Okay.
can.
Fine. So is it visible now?
Sir, no, sir. Understood.
Okay, well, just let me then I think continue with the presentation and then I'll try to do it in between. Okay. The presentation is visible, right?
Yeah. Yes, sir. That's
Okay. So I'll just try it in between and I'll just figure this out. So let's continue with this case. Actually, I've taken screenshots from the scanned image only. So if you had gone through that scanned slide, you would have seen. So one thing, can we have some interaction, or if I can ask question, can somebody respond that way? Is it possible?
Yes, it is possible.
Okay.
And they can also post their question in the chat box, but
Okay.
there is no question yet.
Okay, fine. So I don't know whether if anybody want to volunteer for this case and just tell me a brief overview of what they saw in the scan slide. Doesn't matter. Okay. So I'll tell you. So in that particular slide, which was given to you, so that was a PA stained slide. And there was no significant tubulointerstitial chronicity there, but there were few glomeruli, of which one I have taken a screenshot from that particular slide only, which is showing a segment which is quite different from the others, right? And this segment is a segment of sclerosis. And since it's only a part of the glomerulus is getting sclerosed, we call it segmental sclerosis. And we use the term focal because less than 50%, if you had gone through that entire scan slide, you would have noted that there are around 17 to 18 glomeruli in that slide in this section. And only 3 or 4 are showing these lesions, sclerotic lesions. So that's why it's focal in nature. And even within a given glomerulus, only a segment is getting sclerosed. So it is called as a focal and segmental glomerulosclerosis. So this is a FSGS, or focal and segmental glomerulosclerosis pattern of injury. So if you want to call it. So this was there, and there was no tubulointerstitial fibrosis or anything. You can see the proximal tubules and other things here. And the IF was negative, except for what you are seeing here is entrapment of IgM. So it's an important finding to note although there are no immune complexes here, IgM is a very large molecule. So it has a tendency to get stuck or get entrapped in areas of sclerosis. And then when you do an IF examination, you can actually pick up segmental sclerosis even on an IF section, although you're not seeing the morphology there. So this is what was happening here. This is an IgM slide. And so you had an FSGS lesion on light microscopy, negative IF. And when you do an EM, this is the EM image which we saw, in which there is a diffuse effacement of the food processes. So unlike the image which I had shown you earlier when we were talking about the normal appearances, there is no hair on end appearance of the terminal podocytes here. So all the podocyte food processes have fallen flat on the GBM, and we call this effacement of food processes. So they're not lost, they're very much there. Only thing, they've got merged into each other. So they're effaced. And when you give treatment, and if this patient actually responds to your treatment, all these food processes will again go back to their normal shape. So there will be a realignment of these food processes. But at this point of time, they're all effaced. So it is a diffuse effacement. So this is a primary FSGS. I'll come to that. Why am I calling it primary, or what do you mean by secondary FSGS? Now you think of a scenario where when we do, so there is an FSGS, you have a clinical symptom syndrome where the proteinuria is maybe less than 2 grams, but still you find an FSGS on the biopsy. And then when you do an examination, you do not find this diffuse effacement. You find only a very focal or most of the podocyte food processes are aligned, only focal areas of effacement. There, that FSGS which you are seeing, there is a secondary FSGS. There is a C difference in the way in the meaning of this diagnosis, because a primary FSGS would be treated with first line steroid, second line drugs which are given, then there are third line drugs. But once you know there is a secondary FSGS, you will not treat it. Rather, you would try to focus on the lesion or the reason why that secondary FSGS has developed, right? So the whole approach to the treatment would change when you call it primary versus secondary. Now,
Dr. Alok,
yeah.
there was a question. Somebody was asking that sclerotic lesion, can it be a vascular pole? If you can just.
Okay, I'll go back. Okay, so you need to, so it can be vascular pole also, but the point is there is sclerosis here. So there is loss of capillary architecture. So that is what I was coming to. So when there are subtypes, I'll come to that vascular pole part. But vascular poles will not show you areas of confluent sclerosis and adhesions of glomeruli. That's one part. Secondly, the vascular pole will not show you prominence of podocytes as we are seeing. I'll just start the pointer here. So these structures which my pointer is pointing right now are the podocytes. So what has happened? This was a normal area before it started getting sclerosed. And as it got sclerosed, the capillaries got adhered to each other, but the podocytes which were there, they got huddled together. So wherever you have areas of sclerosis, you will find there is a overlying maybe a huddle or a corona of podocytes which you can see. So these are very helpful pointers for you to ascertain whether that area is actually a sclerotic area, or as somebody has very rightly pointed out, it could actually be a vascular pole. But vascular pole will not show you this huddle of podocytes or even the vacuolization. I think there is a small foam cell also here. So which I am encircling, there is a small foam cell also here. So the foam cells, the pinkish area, the sclerotic area, and the podocyte prominence all point towards a sclerosis rather than a vascular pole, right? But yes, you can have a sclerosis near the vascular pole, and this is where I was coming to. So based on the areas where the sclerosis occurs, there was a class. This was called the Columbia classification, because Columbia University first came up with this. So they recognized different patterns of FSGS lesions, purely morphological. So you had a perihilar, which we were just talking about. So you can have a sclerosis which is near the perihilar region, near the vascular pole. And in practice, we know that many cases of perihilar FSGS are usually secondary in nature, because they occur as a part of the maladaptive process. You don't worry too much about that. Going too much deep into that is not required. But many perihilar FSGS lesions are secondary in nature. Then you have a tip lesion where the FSGS lesion is near the tubular pole, just right diametrically opposite. Yeah. And then you have a cellular variant where you have endocapillary hypercellularity along with this sclerosis. You have a collapsing variant where the GBMs collapse and the podocytes become hyperplastic. And when you don't have any of these four, you call it NOS, right? So our case was kind of NOS. So it doesn't really fit into any of these variants. For FSGS perihilar also, you need to have more than 50% of those glomeruli with perihilar lesion to label it as perihilar. And so there is an algorithmic approach. But what I want to highlight here is with period of time. So this classification probably came out in 2009, or I don't really remember. I think 8 or 9. So over a period of time, we have realized that these morphological patterns really do not have any clinical significance. That's one part of it. Secondly, in a given biopsy, you can have a combination of these patterns. So you can have in one section, you see a collapsing variant, another you see a tip variant. So even if you were to contest that there is an algorithmic approach to diagnosis, the mere presence of these 2 or 3 patterns in the same actually dilutes their clinical significance, because when it was proposed, it was said that FSGS tip has the highest proteinuria, collapsing has the worst prognosis, and so on and so forth. But when you have everything together, 2 or 3 lesions, how do you determine the clinical prognosis? So then we started realizing that relying just on these morphological patterns to determine the clinical outcome or the presentation is not correct. And what instead actually works in clinical practice is trying to determine whether the FSGS is primary or secondary. And that is what we practice globally now. So of course, we look at the biopsy, we see, and if clinician is willing and wants to know the pattern, we definitely tell the pattern, this is the pattern. But at the end of the day, even a collapsing pattern can be secondary, and a tip pattern can be secondary, and a perihilar pattern can be primary. So what matters is whether it is primary or secondary, because that will eventually determine how that patient is treated, right? That's what our final aim is. We should be helping the clinician in giving the correct treatment, not getting stuck with our own classification systems. So that is where the science has evolved now. And now all the centers across the world now aim at determining whether the FSGS lesions or the podocytopathy is primary by looking at the extent of podocyte process effacement. So if there is diffuse effacement, we call it a primary podocytopathy. Or if there is FSGS in LM, it is a primary FSGS. And if it is only focal effacement, we call it a secondary FSGS. So you can see there are so many causes of secondary FSGS. And in many cases, actually, you need to look at these etiologies rather than that pattern and trying to treat everything with steroids alone, right? So that is where the importance of differentiating a primary from a secondary FSGS is there. So in this particular case, we had a diagnosis of a primary FSGS. The reason we called it primary was, number one, the patient had clinical nephrotic syndrome. Now you have another scenario where the patient does not have nephrotic syndrome, right? And you have FSGS lesions. So an FSGS with the patient not having a nephrotic syndrome is very, very unlikely to be primary, right? It has to be secondary. And that's when, again, you need to do an EM and try to figure out how much the effacement is. So you had an FSGS NOS kind of lesions on LM, IF was negative. And since there was diffuse effacement of podocytes for processes, we called it a primary FSGS. So once you call it a primary FSGS, then those steroid therapies, depending on how the patient responds, the primary, the CNIs, whatever the patient has to be given, that will be taken care of. But if you mislabel and if you want to turn them upside down, secondary FSGS would never respond to your steroids. You will only be inducing progressive steroid toxicity in that patient. So it's just, you can imagine the impact your diagnosis has on the eventual outcome of that patient, right? So this is it. So we go to the second case now. So it is very similar. So this, I've intentionally kept these cases together to highlight the differences your analytical process can have on the outcome. So this was again, now this is a smaller boy, this is your 8-year-old boy. And now he's having a sudden onset generalized body swelling. So we call it anasarca diffuse body swelling. Everything looks fine. He doesn't have any hypertension or anything other than that. And significant dyslipidemia, hypoalbuminemia, similar to the present case, the previous case. And this other parameters are absolutely normal. So just as a typical classical nephrotic syndrome. And if you had looked at the biopsy earlier in the scanned slide given, you would have noted that it was actually looking pretty okay. So there were no abnormalities there per se. And this is a screenshot from the biopsy itself. So you can have this glomerulus, and if you can identify the stain by looking at the Bowman's capsule. You can see it is nice magenta colored Bowman's capsule. And you can also nicely see the mesangial matrix area. So this is an absolutely normal glomerulus. And this is exactly how all the glomeruli were in that particular biopsy. So you can have a normal mesangial matrix. There is no thickening of GBMs, no increase in cellularity. Even the tubules here, you can see. So my pointer here is placed at a proximal tubule. Why I'm calling it? Because I can see this pinkish brush border here, prominent brush border, right? So this is a proximal tubule. And just next to it is a distal tubule. Why is it distal tubule? Because the amount of cytoplasm is also very less. That's one thing. Secondly, it has no or very minimal brush border. So you can identify the proximal and distal tubules by looking at the light microscopy also. So this is a cluster of distal tubules. This is a proximal tubule. This is the proximal tubule. This is a proximal tubule. Even this one is a proximal tubule, right? So it's important to identify the proximal and distal tubules because different diseases arises in proximal tubule, proximal tubulopathies, and proximal tubules are the site where they have better vascularity. So a lot of ischemic ATNs, tubular injuries actually predominantly affect the proximal tubules, right? But as far as this case is concerned, we could not really find any light microscopic abnormality. The DIF was also completely negative in this case. So again, now we need to go to the EM to determine what it is. And this is what the EM showed again. So you have a diffuse effacement of the foot processes again. So if you can recall, the ultrastructural appearance in this case and the case we'd seen earlier is identical. There is no difference. So remember that in a primary FSGS and a minimal change disease, the ultrastructure remains the same. The same diffuse foot process effacement you would see in both the condition. It is your light microscopic examination would determine what you call it. So if you really don't see any FSGS or if you you see just normal glomeruli and the patient has nephrotic syndrome, of course, then you call it a minimal change disease pattern. When you get an FSGS with diffuse effacement, you call it a primary FSGS, right? So EM does not help you to distinguish between MCD and FSGS. Please remember this because this question is often asked by students and even nephrologists many times. Can we pick up early FSGS by doing EM? The answer is no, right? So there is, you may debate the existence of an early FSGS, but even in that scenario, you will need to pick it up on light microscopy, not on ultrastructural examination. So EM wise, both primary FSGS and a minimal change disease would look exactly the same, right? So the use of EM actually is in determining whether the FSGS is primary or secondary, and when there is no abnormality on light microscopy, confirming that diagnosis as nephrotic, as a minimal change disease. So if you look at it from a different angle, minimal change disease actually is a diagnosis of electron microscopy, right? So unless you prove that there is a primary podocytopathy, you cannot call it minimal change. Although we do it in practice because the overall clinical scenario fits in well, but strictly speaking, you need to document the diffuse foot process effacement before you label something as minimal change disease. So you can have so many diseases. So if a patient is presenting with creatinine of 4 and a minimal proteinuria, and you don't find anything on light microscopy, you don't label it as minimal change disease, right? So you need to have the correct clinical context. Unless the patient has a nephrotic syndrome or a significant nephrotic proteinuria, you don't label it as minimal change disease short of EM examination just because the glomeruli look okay, right? Please remember this. So why we called it minimal change was because there was a clinical presentation of nephrotic syndrome. The glomeruli were absolutely normal on LM. The IF studies were negative, and we could document the diffuse podocyte foot process effacement to any examination. So that's where, when you have all these 4 conditions fulfilled, only then you call that particular case as a minimal change disease, right? Okay. So these were the 2 cases which I wanted to highlight, the podocytopathies, if you want to call it. So if you see here, so there were no deposits in these cases, right? So now there will be cases where you have glomerular disease with deposits, and that is where we will head in our next case. Okay.
Dr. Alok, there is a question.
Yeah.
They have asked what could be the pathological basis for steroid resistance in MCD?
Okay. So that's a good question. So since we are not talking about too much about the non-biopsy aspects here, so you must have seen, so there are certain things which are idiopathic. So you really can't assign a reason for steroid resistance. That's one part. Secondly, not all patients are who are resistant initially continue to remain so. So there is something called as late responders also. So just because a patient has not responded at 3 weeks doesn't mean that he will not respond to steroids 6 months or 4 months down the line. So there are patients who don't respond at initially, but now when you do a biopsy and you're sure that there is nothing to worry about, or it's only FSGS, or is it, you again give steroids for some time, and some of the patients actually respond after that, right? So that's one part of it. So you can't really assign a pathologic basis there because everything is same. Secondly, there could be genetic basis, which we are not dealing with here. But then there is a form of FSGS or a podocytopathy or nephrotic syndrome, which has a genetic basis. And those are the cases where they will either look like a minimal change disease or look like an FSGS. But since the etiology is a genetic defect, the response to steroids will not be there. So that is if you want to call it a pathologic basis for steroid resistance. Second part of it, if you look at on a case-to-case basis, a good number of cases of FSGS are steroid resistant. So they don't respond to the initial doses of steroids. And that is the reason a good number of cases of FSGS actually land up in CKD over a period of time. So they don't respond to steroids. Some of them even don't respond to the second line of drugs like the calcineurin inhibitors, and they slowly keep on progressing towards end-stage renal disease. And many of those transplants which you see happening down the line are for primary FSGS lesions. So if you want to ask me about the pathological basis, yes, FSGS is one lesion which I will not like to see. That is definitely a indicator of this thing, and some genetic basis if you have. So most of the cases of minimal changes, if they do not have a genetic underlying etiology, would at some point of the other would definitely respond to steroids. Although there are a lot of clinical variations even there, but as a general, if you want to call it general concept, you can assume that if it is a minimal change disease, it's a good diagnosis, and these patients are expected to respond to steroids. Right? Okay, so I think we can move on to the next case.
Sir, we have one more question.
Yeah.
Just asking that can it be an unrepresented FSGS?
Okay, so see, that possibility can never be excluded. So we pathologists are good at that, cannot be excluded. But let me tell you, so you should have a reason to call it. We do that. So we often say sometimes in our reports, we say that I cannot exclude FSGS, but then you should have a very valid reason to say that. The reason being, if you have a biopsy, which we saw this case, right? 8-year-old child. In this case, suppose we take it other way around. So if you have a biopsy of an 8-year-old child in which the glomeruli are absolutely normal, okay, but then I'm finding some areas of tubular atrophy, interstitial fibrosis, although they may be very small, but they are there. I do not expect this in an 8-year-old child, right? So there I would say, yes, although I'm not seeing an FSGS lesion upfront in my biopsy, it could be a sampling error, but still there is a possibility that an FSGS has not been sampled in this biopsy course. So just remember, so how much does a biopsy sample? It's only a centimeter core out of the entire kidney. So there is always a chance of sampling error, but thankfully the disease processes are such that we really do not bear the brunt of the sampling processes in majority of cases. But yes, if you find areas of tubular atrophy, interstitial fibrosis, interstitial foam cells, or any unusual finding, you have to, in the context of nephrotic syndrome, there is a possibility that you may be unsampled FSGS. But if the tubular interstitium was absolutely fine, just as in this case, there is absolutely nothing in the tubular interstitium, no fibrosis, nothing, then you probably should not be calling it that way. There is then it becomes a waste basket, right? For everything you can call it. But you should have your valid reasons to say why you are suspecting an FSGS which is not there, right? That way. Okay, so we go on.
Sir, one more question,
Yeah.
sir.
Sure.
What is the minimum cutoff for number of glomeruli showing sclerosis to call it FSGS?
Okay, so there cannot be, right? So even if one, you please go ahead and call it FSGS. So don't bother too much about that. So problem is, see, there are a lot of mathematical cutoffs given, but trust me, so you take those cutoffs in context of a given case. So don't wait for a biopsy to call it adequate unless you have 10 glomeruli, right? Don't do that. So if you have 6 glomeruli and 3 are showing segmental sclerosis, call it FSGS. There is no problem, right? So mathematics should also be applied in the correct context. Just like for crescentic, we have a 50% cutoff. But if you have 30% or 40%, won't you call it crescentic? So those are the decisions which you have to take it on a case-to-case basis. So even if a single glomerular shows a segmental sclerosis lesion, it has to be documented and reported that way. Okay. And suppose there is a condition where you have only one glomerulus in the biopsy, and that glomerulus is showing segmental sclerosis. So you don't have a focal criteria on which you can create your denominator, right? 50%. You have only just one. But even in that case, you have to tell that there is a segmental sclerosis in that glomerulus. Okay. So it is an important. So, and similarly, there is another scenario which I'm sure the question was aimed at that. So you have 10 glomeruli, 7 are showing sclerosis, segmental sclerosis. Still call it segmental sclerosis. Maybe you can omit that focal if you want to. That may be a sampling error, or maybe the sclerosis is so widespread that it has broken your mathematical barriers. So it has become more and more than 50%. It can happen. See, after all, you are sampling a very small area, right? But even if it is in one, please report it and document it. And if you're able to satisfy the criteria of focal, please call it focal and segmental glomeruloscopy. These are just names. See, remember, in renal pathology, it is all about patterns. So it is not that if you call something as segmental sclerosis, the clinician will start thinking of a different disease. Or if you add a focal or you delete a focal, clinician will start thinking of a different disease. So the important thing is you have communicated the pattern of injury, and the entire renal pathology revolves around patterns. So whatever I have spoken just now, or even I'll speak in later slides also, it's predominantly pattern-based approach. So it's the patterns, the same pattern can have multiple etiologies. Like for membranoproliferative, there can be 15 etiologies. For an FSGS, there can be so many etiologies. We just saw that, right? So it's important to understand and note and document the patterns. And then what context that pattern is arising then needs to be figured out both by a combined effort of pathologist and the clinician. Okay. Fine. Can we go to the next case now?
Yes,
Yes, sir.
yes. We have less time left.
Yeah, I
So
know.
a bit.
We'll quickly go through the slides. So it's 1.5 hours, right? Dr. Prasenjit, how much time do we have?
It was for 1 hour, but you
Ah.
can take 10-15 minutes more.
Okay,
No
okay.
issue.
So quickly we'll go through the remaining cases. There's 2-3 more are remaining. So this is also a similar case. It's nephrotic syndrome. But what has happened here is if you had looked at the biopsy, you would see that instead of normal thin GBMs, GBMs were quite thick there, right? And I think I had also given a slide of silver stain there. If you had seen that silver stain slide, this is a snapshot from one of those slides. You can see that there are a lot of abnormalities in the GBMs. So you can see these spikes, mottling, and all that. Meaning there is something getting deposited in the glomeruli, which is leading to that particular morphological pattern. So this is, and when we did an IF on this case, this revealed a glomerular capillary wall staining for IgG. And when we did the EM, you could see these nice subepithelial electron dense deposits, right? So this was a case of a membranous pattern glomerulopathy. So why we called it a membranous? Because GBMs were thick. So first of all, patient had nephrotic proteinuria. He had thick GBMs with evidence of mottling and spikes. You can see go back and see the slides again. You will see nice spikes and mottling there. We had IgG staining. And then when we did the EM, the subepithelial immune complex deposit was seen. So you don't need an EM to make a diagnosis of membranous pattern GN. You can make your diagnosis very well based on light microscopic and immunofluorescence findings. Okay. So that's one other pattern. The next two patterns are almost similar, but I'll tell you the differences as we go along. Just 5-10 minutes more. So the case 4 was a small child, and he had a history of fever, chills, upper respiratory tract infections. And when you look at the urine examination, there were a lot of RBCs. So he had a nephritic syndrome, also kind of a picture. And if you notice the C3, it was slightly low, 66 milligram %, and C4 was normal. And renal functions were more or less okay. And this is what you saw. This is a snapshot from the scanned slide which you had given. So you can see it is very cellular compared to whatever you have seen earlier. This is showing a lot of cellularity. And if you go into the higher power, you can see a lot of these cells are actually inside the glomerular capillaries. So we call it endocapillary hypercellularity. And many of these cells are neutrophils. So this is an exudative pattern of glomerulonephritis. So it's a diffuse proliferative because it is endocapillary proliferation. If you want to add exudative because of neutrophil, you can add that also. It's a diffuse proliferative and exudative kind of a glomerulonephritis pattern. And same thing on pass, if you can, the reason for giving PA stain was to notice the thickness of the GBM. So GBMs do not appear significantly thickened in this particular case. So it is proliferative, but I don't really appreciate any significant GBM thickening. And when you did an IF for this, there was a lot of C3 and significant but lesser amounts of IgG in a capillary wall and mesangial areas. All of it was there. And when we did a electron microscopy examination, you could see it was an endocapillary. So the cells are occupying these spaces. And if you carefully look where I'm showing, these are deposits on the subepithelial and the mesangial aspects. And on higher power, you could actually see a large subepithelial deposit, which is looking like a hump, right? So you have a diffuse endocapillary proliferative GN with IgG-C3 deposits. And on EM, you have large subepithelial humps along with mesangial and subendothelial deposits. So that's what you call it. So you call it a diffuse proliferative glomerulonephritis pattern of injury. And since you had a lot of humps, there was no MPGN pattern, you call it likely an infection related GN. So what we used to call it is a post streptococcal GN. Now we don't call it post streptococcal because you have many etiologies other than streptococcus also here. So we call it an infection related GN now. So instead of PSGN or PIGN, it is more logical or scientific to call it IRGN, right? Just remember that. The next case is similar, same age of the child, but now this child has been having these symptoms for some time. The biopsy was not consented earlier and almost same picture as previous. And now you see this is a snapshot from the scanned slide only. So if you see the differences between these two cases with almost similar clinical presentation is the capillaries in this particular case are significantly more thickened. You have a prominent lobulation, accentuation of the lobulation of the GBM. And these capillaries are actually duplicated, thickened and duplicated. And this is the typical membranoproliferative pattern of injury. Okay. And when we did a EM, it only showed IF, it only showed C3, IG, IgG negative, IgM negative, C1q negative, kappa negative, negative. So only C3 staining. So this is one particular pattern of diffuse proliferative glomerulonephritis showing only C3. And when you do an EM, you would see that this is showing a lot of subendothelial and mesangial deposits. And this particular glomerular capillary is showing reduplication. So this is the original capillary. This is the reduplicated capillary. This is the neocapillary, and in between you can see a lot of immune deposits, right? So this is a MPGN pattern of injury, which is characterized by thickening and reduplication. And since there was only C3 staining, we called it as a C3 glomerulonephritis. So you can have IgG, C3, C1q, then we call it an immune complex mediated MPGN. If you have only C3, you call it only C3 mediated MPGN pattern. And when you have only C3, you have to do EM to differentiate it from dense deposit disease. It's very important. And this is our dense deposit disease case. So you will have a case which is identical to what we saw till the IF stage. But when you do an EM, you would see a diffuse ribbon-like staining of electron-dense material. So this is dense deposit disease. But our case was slightly different. It was showing conventional deposits. So we called it C3 glomerulonephritis. Had it been this, we would have called it dense deposit disease. Why is it diagnosing so important? Because dense deposit disease will almost always come back in the renal allograft. So if this patient goes into ESRD, which it will almost always will, you will probably hold yourself back from doing a transplantation if your diagnosis was dense deposit disease, knowing very well that it is very, very likely to come back in the graft. So that is the importance of diagnosing it early or correctly by using appropriate methods.
Sir, we have a
Alok,
question.
Yeah.
Sir, you can ask, sir.
Some related questions actually.
Yeah.
Somebody asked how often do we need to do electron microscopy in routine practice for renal biopsy? And another question is, do we need to subclassify MPGN? That you already told, just
Okay.
you can highlight.
So I talked about the MPGN, so you have to subclassify. So even if you are having a conventional immune complex MPGN with IgG, C3, C1q, you need to figure out whether what those complexes are. They could even be having some substructure there. It could be immunotactoid, it could be fibrillary. So you need to be sure whether those deposits are true conventional immune complexes. And I just told about the dense deposit. So dense deposit is a very bad news for the kidney, and because it comes back. And till recently, there was no other way of doing it except EM. But by the work, we also participated in that work. There was a paper recently published. So we have now discovered that most of these deposits are actually composed of apolipoprotein E. So now you have an IHC marker for dense deposit disease. So which is a very, very great step going forward. So even without doing an electron microscopy, if you do an ApoE staining and it comes out in a linear continuous fashion, without doing an EM, you can diagnose a dense deposit disease. So that's one new development which has taken in a place. The second part of the question was, is it necessary to EM in all the cases? If you ask me, yes. So it does contribute to almost every case, but of course it's not possible every time. But what is ideal is clinicians also need to be sensitized when they're doing a biopsy, at least take a sample for electron microscopy. So that's a very good practice. So even if you don't do an actual examination, either you can keep that tissue or you can at least process it till the resin block stage. And whenever required, you can do an electron microscopy examination, because you cannot predict which case will require EM by looking at the clinical presentation or even the biopsy, right? So something which you cannot predict, you cannot even give a recommendation on. If these many cases you need and these many, you cannot predict it upfront. So ideally it should be done in all, but the recommendation is at least collect a sample for EM in all the cases wherever it is possible, right? So the last case, so it's an easy one. So I gave you a predominant easy case because the etiology is also given here. So this patient had a pulmonary TB 10 years back, and now he's presented with nephrotic syndrome 10 years after his pulmonary TB. He has 3+ protein. Everything else looks pretty much okay. But you can see the BP is slightly on the lower side, which is again a indication of the diagnosis. And what happened in this case was, so this is a snapshot from the slide, which I had shown you, given to you. So you can see there is something getting deposited in these mesangial areas, GBM. And if you are careful to look at, same material was also deposited in a lot of vessels, both in the hilar arterioles, the smaller arteries, and even in the vessels which were in the medullary area. And this material was, I had also given a congruent slide, congruent stain, and you could see this material was congophilic. So if you could do a polarization on this particular slide, this is how it will look. It will give a nice greenish bifringence on polarized light. And I talked about the stains also, right? So usually the amyloid is PA stain negative. It will not become bright red or magenta with this thing. And most of the times it does not become black with silver also. So that could be an indication when you do your special stains, you can actually predict, oh, this is going to be amyloid. And if you're not doing congruent in all your sections, which you should do, then you can do a congruent and just confirm whether that stain is, you can polarize and see if you can confirm your amyloid deposits in this, right? Now, the next step of amyloid diagnosis is trying to type it. So we won't go much into detail it, but in this particular case, because there was a history of pulmonary tuberculosis, it was important to ascertain whether this particular amyloid was primary or secondary. So we did an SAA stain, which is called the serum amyloid associated protein, which was positive for IHC in this. So this confirmed that this particular amyloid was actually secondary in nature. And in the given clinical context, it is likely associated with that pulmonary tuberculosis, which actually happened 10 years back. But remember, even if it occurred 10 years back, the amyloid deposits can form there is no predictable timeline to which amyloid deposits can form after an initial infective insult. So it can be 10 years, it could be 2 years, it can even be 20 years, but still the etiology remains the same, right?
But Dr. Alok,
Yeah.
not any single IHC marker are so sensitive and specific.
Mhm.
So routinely, if you have to subclassify amyloidosis,
Mhm.
what all stains do you do?
Okay. So at a practical level, see, the first step in typing amyloid is your immunofluorescence. So one of the most common types of amyloid deposits are light chain amyloid. So you will be able to pick up your amyloid deposits by doing your routine kappa and lambda staining. So most of the times the amyloid deposits have a tendency to be lambda light chain restricted. So that's the first step. The second step, if your IF is negative, then you are the most logical next step is doing a panel of IHC. So if you look at the distribution of cases in our country and with the TB and other infections, the possibility of secondary amyloidosis in our country is very high. So once you've excluded a primary amyloidosis by doing an immunofluorescence examination, the next step would be to do an IHC for SAA. SA is the most common IHC positive IHC type of amyloid which gets deposited in secondary post-infection related and post other things related. So you would pick up almost 60 to 70% cases by this. Now the remaining amyloids are tricky because IHC, of course, is you cannot have so there are more than 40 amyloid types protein described. You can't possibly keep an IHC panel of 40 IHC markers and keep on putting them one after the other, right? It's not possible. So you can have the most common ones. After your kappa and lambda, you do an SAA. Then the third most common in certain clinical conditions, not in kidney so much, but it's transthyretin. So you can have that panel of transthyretin, kappa, lambda, SAA, and will solve most of your cases. Whatever remains are the rarer types. And then you need to go to the gold standard methodology. So the gold standard method of diagnosing amyloid is by doing laser capture microdissection of the specific area. You need to dissect out that area from the tissue and then subject that tissue to mass spectroscopy. So that is the gold standard. And in rare cases of amyloid or cases which we cannot actually diagnose by doing IHC, you have to subject them to mass spectroscopy. And there's another trick here, problem I should tell you, since this point has come out already. Even an SAA stain, for example, it has almost 30% false positivity rate, so which is very, very high. So of 100 cases which you give out, sign out as SAA positive, 20 to 30 will be false positives. That is a caveat of immunohistochemistry, because amyloid by nature is a very sticky protein. So it has a tendency to non-specifically entrap a lot of things. I told you about IgM, right? Similarly, it has a tendency to entrap a lot of things and give a lot of false positives. So that is again, the use of mass spectroscopy and microdissection comes in there. So this is why how we are right now. And we need to work with whatever is available with us. But yes, by doing an SAA and kappa and lambda in the given clinical context will probably solve at least 70% of cases of clinical amyloidosis for you. That way. Thank you. So this is all I had to say in this, and the questions are most welcome.
So any more question, Dr. Bala? I can't see any, or you can ask, anyone can ask if you have any other question.
Please feel free to ask.
You can unmute everyone, Bala.
They already, sir. I've given them permission. They can unmute
Okay,
and ask.
okay. But while we are waiting for the questions, Dr. Alok, you have brushed up my knowledge also, because I don't see nowadays renal biopsies, and it was so fantastic. And we'll come coming back to you, because I really admire your experience on renal biopsies, and we are growing a small community. Okay, so future focused presentations also will ask for you.
Be a pleasure.
Somebody has asked, can we have another session on non-glomerular medical renal disease? We are already talking about that, and we'll definitely repeat Dr. Alok after some of the presentations to make it more interesting. So if there is no other question, thank you, Dr. Alok, for your time, and thank you everyone for giving time. This is a working day at the end of the day, and we'll share the feedbacks shortly, and we'll see you next month then. Thank
So
you,
thank you
Dr.
for
Alok.
the efforts
Thank
that you sent the
Thank
scan
you.
slides. Thank you for putting in the effort for us, the students. Sir. Thank you, sir.
Thank you.
Thank you so
Bye.
much.
Thank you.
Thank you.
Thanks a lot. Thank you. Bye.